Welcome. If you are listening to this right now, I know exactly where you are. You are a resident preparing for your FRCS plastic surgery board exams.
Yeah, you're deep in the thick of it.
You really are. So our mission for today's deep dive is simple. We're going to do a rapid-fire, targeted mastery of radial nerve entrapment and compression syndromes.
Right, covering everything from the shoulder all the way down to the wrist.
Exactly. But before we dive into the anatomy, take a quick second to hit that follow button on whatever app you're using.
Yeah, it really helps.
And if you learn a valuable exam pearl today, please leave us a rating. Also, I highly recommend upgrading to a premium subscription.
Oh, absolutely. That gives you access to the dedicated journal club.
Right, the journal club and the clinical cases deep dives. You definitely want those for the later stages of your revision.
They're essential.
Okay, format-wise, we're doing a high-yield question and explanation style interview. No fluff, just to maximize your study time.
Let's get right to it.
So, to understand compression, you really must first precisely trace the nerve's anatomical path down the arm.
You have to know the roadmap.
Right. Think of the radial nerve as this massive interstate highway carrying cargo from the C5 to T1 factories. How exactly does it navigate out of the shoulder and down the arm before hitting the major toll plaza at the elbow?
Well, it's the largest branch of the plexus, continuing straight from the posterior cord.
Okay.
And it immediately passes through the triangular space. For the exam, you need to know those boundaries. It's the humerus laterally, the long head of the triceps medially, and the teres major superiorly.
Got it. So it slips through there and hits the spiral groove.
Exactly. But it doesn't stay posterior forever. It has to come around to the front, so it pierces the lateral intermuscular septum.
And there's a very specific measurement examiners want here.
Yeah, there is. It's exactly 10 to 12 centimeters proximal to the lateral epicondyle.
10 to 12 centimeters.
Right.
Why does that specific number matter so much?
Because if you're doing a surgical approach to the humerus, knowing that rule dictates where you can safely place your retractors.
Without transecting the nerve.
Exactly. You do not want to cut that. So once it's in the anterior compartment, it runs distally between the brachialis and the brachioradialis.
Just tucked in that groove, passing right over the radiocapitellar joint.
Right. And crucially, right at that radiocapitellar joint, it bifurcates.
It splits.
Yeah, it splits into the superficial radial nerve, which is pure sensory, and the posterior interosseous nerve, or PI, which is predominantly motor.
Okay, so having reached the elbow in our anatomical roadmap, we hit the first major bottleneck.
The radial tunnel.
The radial tunnel. This is the classic site for radial tunnel syndrome. So map the boundaries of this tunnel for us, and then what are the four specific entrapment culprits?
Well, the tunnel itself is about 5 centimeters long. The medial boundary is the brachialis and the biceps tendon.
Right.
The anterolateral boundary is the mobile wad. And the floor is literally the joint capsule itself.
That's a key anatomical point. And it ends where?
At the distal edge of the supinator muscle.
Okay, let's unpack this. We have this 5-centimeter tube. What are the four specific things that actually choke the nerve here?
Right. So culprit 1 is fibrous bands to the radiohumeral joint. Culprit 2 is the leash of Henry.
The leash of Henry. Those are blood vessels, right?
Yeah, exactly. It's a fan of radial recurrent vessels crossing over the nerve. Culprit 3 is the tendinous margin of the ECRB.
Extensor carpi radialis brevis.
Right. And finally, culprit 4, the most famous one, is the arcade of Froese.
Right, spelled F-R-O-H-S-E, that fibrous band on the supinator.
Exactly.
But wait, I have to push back here. If the nerve is completely compressed by all these structures, why isn't there motor or sensory loss?
That's the paradox of radial tunnel syndrome. The predominant symptom is purely pain.
Just pain. But patients always complain about their grip being weak.
I know, but the grip weakness is purely secondary to the pain. It's a pain inhibition reflex, not a true motor loss.
Oh, I see. So how does a candidate confidently distinguish this from a run-of-the-mill tennis elbow in an exam scenario, both present with pain and weak grip?
It comes down to targeted palpation. In radial tunnel syndrome, the tenderness is a few centimeters distal, right over the nerve in the muscle mass.
Yeah, in tennis elbow.
The tenderness is directly on the lateral epicondyle itself.
Right, right. And then there are the provocative tests. Talk about the middle finger test.
Yeah, so you ask the patient to extend their middle finger against resistance while keeping their elbow completely straight.
And that triggers the pain.
Exactly, because it forces the ECRB to aggressively fire, and that tendinous margin we talked about pushes directly onto the nerve.
Wow. And the other test is resisted supination, right?
Yeah, with an extended arm. It forces the supinator to work alone, which tightens that arcade of frost down on the nerve.
So treatment-wise, we start non-surgical, splinting against wrist flexion,
Right, and maybe a localized steroid injection.
which also helps eliminate tennis elbow if you're trying to rule it out.
Exactly, it clarifies the diagnosis. And if that fails, surgery simply releases those 4 exact compression points.
Okay, so we just established that radial tunnel syndrome is characterized by pain without true weakness. But what happens if the compression isolates the deep motor dominant branch after the bifurcation?
Then you are looking at posterior interosseous nerve, or PIN syndrome.
Right, so outline the causes of PIN syndrome for me.
The POA is motor to most of the forearm extensors. It terminates as a tiny, purely sensory branch at the base of the 4th extensor compartment.
Just for joint proprioception.
Exactly. So causes for compression here are varied. You have trauma, like radial head fractures or elbow dislocation.
Because they physically stretch the nerve against the bone?
Right. Then you have inflammation, like rheumatoid synovitis, swellings, like lipomas or ganglia, and of course, iatrogenic causes.
Iatrogenic. Like a surgeon making a mistake.
Yeah, like surgically plating a fractured radius or even an injection for tennis elbow that goes too deep.
So how does the clinical picture differ from radial tunnel?
You see actual profound weakness. Weakness of the finger, thumb, and wrist extensors.
But what about sensory disturbance?
Absolutely none. If the patient has dysesthesia or numbness on the back of the hand, it's a more proximal lesion. PIN syndrome has no sensory loss.
Okay, here is a classic board-style trick question. So what does this all mean for wrist extension? If the PIN supplies the extensors, does the patient completely lose the ability to extend their wrist?
No, they don't. And this is vital. Wrist extension is actually preserved, but it is radially deviated.
Wait, preserved but radially deviated. Why?
Because of the millimeter-level anatomy. The branch that supplies the extensor carpi radialis longus, the ECRL, branches off the radial nerve proximal to the pin.
Oh, wow. So before the compression.
Exactly. So the ECRL is totally healthy. When they try to extend, the ECRL pulls up into the radial side.
And normally the extensor carpi ulnaris balances that out.
Right, but the ECU is innervated by the pin, and so it's paralyzed.
So ECRL just pulls unopposed.
What opposed radial pull, exactly.
That is such a crucial exam pearl. So for treatment, you do splintage to protect the paralyzed muscles and surgical decompression if there's no spontaneous recovery.
Yep, straightforward.
Okay, so we followed the deep motor branch into the forearm. Now, we must travel back up to the bifurcation and follow the second path.
The superficial sensory branch down to the wrist.
Right, the superficial sibling. This brings us to Wartenberg syndrome.
Chiralgia paresthetica.
Exactly. What's the anatomical setup here?
The nerve emerges from beneath the brachioradialis tendon, and you need the exact measurement here too. It's 6 to 8 centimeters proximal to the radial styloid.
6 to 8 centimeters.
Yeah. Then it splits to supply sensation to the dorsum of the radial 3.5 fingers.
So how does it get compressed?
Usually it's pinched, like a scissoring action between the brachioradialis and the ECRL during forearm pronation.
So repetitive pronation and supination causes it.
Right, or external compression. Tight bracelets, handcuffs, tight watches right over that spot.
Okay, here's where it gets really interesting for an exam scenario. You have a patient with wrist pain, and they test positive on Finkelstein's test. How do you prove to the examiner it's Wartenberg's and not de Quervain's disease?
That's a great question because Finkelstein's stretches the first dorsal compartment, which aggravates de Quervain's.
Right.
But structurally, that superficial radial nerve runs right over that same area, so Finkelstein's pulls the nerve taut as well. Both will test positive.
So what's the difference?
De Quervain's has no sensory disturbance.
Because it's just tendon inflammation.
Exactly. But Wartenberg's will present with paresthesia and true numbness, plus pain of percussion in de Quervain's is just local tenderness.
Oh, I see.
Yeah, whereas tapping the nerve in Wartenberg's gives a true tunnel sign, like electric shocks down the fingers.
Right, you're pinging the nerve directly. That makes perfect sense. So you treat it by removing the inciting jewelry or watch maybe steroid injections.
Yeah, and if you operate, you use a volar surgical approach to release the fascia between the brachioradialis and ECRL.
A volar approach, just to keep away from those superficial nerve branches.
Exactly. Keep it safe.
So to sum this all up, what we're really seeing is how highly specific millimeter-level anatomical knowledge directly translates into identifying the correct syndrome.
It absolutely does. You can't just memorize symptoms.
No, you have to understand the mechanics to pass the board exams. And I want to leave you with a final thought to ponder based on this material. Think about the sheer anatomical irony of iatrogenic injuries here.
Oh, it's wild when you think about it.
Right. I mean, a standard steroid injection meant to relieve tennis elbow can inadvertently cause peon syndrome.
Yeah, just by going a few millimeters too deep.
And surgically plating a fractured radius can do the exact same thing if you blindly place a retractor.
It really forces you to respect the anatomy.
It forces you to constantly consider where the tip of your needle or the edge of your retractor is in relation to that nerve. It's unforgiving.
Extremely.
Well, if you are fuzzy on any of the anatomical landmarks, the exact measurements, or the test we discussed today, drop a comment or a question.
Yeah, we'd love to hear from you.
We want to make sure you have this locked down. Good luck on your FRCS preparation. Keep grinding, and we'll see you on the next deep dive.